Maybe. So now we're just going to kind of pick up where we left off with popliteal artery entrapment syndrome. So this is a condition where the popliteal artery actually gets caught and entrapped between the head of the femur and the head of this gastrocnemius muscle. So this is usually found in young men. It's a congenital anomaly that people are born with. Could be also related to trauma. So maybe if the person had some sort of like traumatic knee injury, they could potentially develop popliteal artery entrapment syndrome. So this has to do when they're exercising and they're bending their knee. You get this repetitive, when the muscle elongates and tenses, it actually stretches and then compresses that artery between the muscle and the bone. So we can diagnose this by putting the patient in a couple of different positions, flexing their leg, extending out their leg, and it'll actually, when that muscle stretches and tenses, it stretches and then compresses the artery, and we can actually see changes in velocity and changes in the waveforms when they flex their foot. So we have them do plantar flexion, dorsiflexion. So here we can just see our two waveforms. So this is the left leg relaxed in a neutral position, and then comparing it to the right leg when they do the flexor plantar flexion. We notice that the velocities increase because we're basically creating a stenotic lesion. So that tendon is flexing, the muscle's flexing, it's compressing that artery up against the bone, and we get narrowing of that vessel and turbulent or higher elevated velocities. So here they're measuring, looks like, where they go, 83, and this is 140, almost 130. So that's the test that we can do to rule out popliteal artery entrapment syndrome. So if they give you questions about this, it's usually found in men, but young men that don't have any sort of, predisposing risk factors for peripheral arterial disease. So they're having these symptoms of claudication, they're getting cramping because there's reduced blood flow getting to that affected leg. They have typically no other risk factors that would suggest atherosclerosis. So then you should start thinking along the lines of maybe popliteal artery entrapment syndrome. So with this, they actually use the little PPG sensors, placed them on the patient's first digit, the great toe on each foot. Then they had the patient, resting, they look symmetric. And then when they did plantar flexion, we see reduction of flow on the left foot. Dorsiflexion, even less flow. Whereas with the great toe with plantar and dorsiflexion, we get no changes in that flow on the right side. So the waveforms stay within normal limits. Skip over that guy. So compartment syndromes is another important one. So I skipped over these two, this cystic adventitial disease. Compartment syndrome. So compartment syndrome describes a condition where we get compression of the nerves and the blood vessels within an enclosed space. So our body has various muscular compartments in which those blood vessels run through. So this is more specific to when we're talking about the extremities. And the patient has to undergo some sort of physical trauma, some sort of blunt force trauma. So this could be a motor vehicle accident, it could be some sort of trauma injury, you get hit in the leg with a baseball bat, maybe a lacrosse player, they get hit in the thigh with a lacrosse ball. They wind up with intense swelling in that area of trauma. And that intense swelling actually is sufficient enough to actually compress the nerves and compress the blood vessels that are running through that muscular compartment. So this is a critical condition because if those pressures, they get high enough and there's enough swelling, it can actually cut off blood flow down the extremity, which can lead to eventually, necrosis and death of that tissue. or it could lead to permanent nerve damage. So in the hospital, they actually have a device where they can measure the pressures in the various muscular compartments, and if need be, it would perform what's called a fasciotomy, where they actually cut open the muscle and expose the vessels, the nerves, to relieve the pressure within that compartment until that the inflammation starts to calm down, and then they could sew you back up, stitch it back up.
So you said it is caused by trauma?
So yeah, it's caused by trauma. You need some sort of trauma to cause compartment syndrome. So if you get a question, like patient is status post motor vehicle accident, and like you see, they give you some pictures of waveforms, in the extremities, because they're going to have symptoms too. They'll start experiencing some of those symptoms of pain, paresthesia, like a burning and tingling. They might have weakness in the muscle that's involved. There might be sensory deficit as a result of the nerve compression. They might all of a sudden lose their pulses in one of the extremities. So we can see changes in impedance as a result of that calf swelling. So this was a patient when they were imaging. A represents the proximal posterior tibial artery. So this is in the patient's calf. They have calf swelling. So that proximal posterior tibial artery, before the area that's swollen, the compartment that's swollen, we see something away from that looks very high resistance. So we're just kind of getting these systolic dumps, like blood flow is getting down, and then it's meeting something that's compressing that vessel. There's no diastolic flow at all. And then we get the distal posterior tibial artery. So on the other side of that swelling, we see, very low resistant flow. So the muscles trying to draw that blood in, the vessels have become very dilated on the other side because they're starving for blood. And we get a waveform that looks monophasic, very low resistant now. So, something happened between there and there. So this would be enough to diagnose a patient with compartment syndrome, particularly when we compare it to the opposite leg, asymptomatic leg. At the level of the swelling, we see nice normal looking triphasic waveform. So we'd expect to see this at all levels, but instead we're seeing this above it, showing high resistant flow, and then below it, low resistant flow. So when we're talking about peripheral arteries, anytime we see low resistant flow, we know that we're after some sort of blockage or stenosis, like something occurred to change it, from a high resistant triphasic into this low resistant flow pattern. So another condition is thoracic outlet syndrome. So now we're moving up to the upper extremity. So this is something that a condition that where we get compression of either the nerve or the vessels, the artery or vein, between the first rib and the scaling muscle in our thoracic outlet. So these patients will present with numbness, tingling of the upper extremities or digits. And usually this condition manifests itself when the patient is put in various positions. So maybe they're some sort of construction worker. They only feel it when they raise their arms over their head, or they're an athlete, say a pitcher, for instance, and when they're pitching and that repetitive motion, they get the constant compression of that vessel between that first rib and the muscle. So when we're actually testing for thoracic outlet syndrome, we're going to put the patient in various different positions to try and reproduce those symptoms of compression to see if it truly is thoracic outlet syndrome. We can use the PPG sensors, put them on the digits. We can use Doppler, the little pencil probe, the handheld Doppler. We can even use the ultrasound machine to try and Doppler the vessels as we're putting these patients through some of these various positions. We're going to go a little further into detail about the actual tests and the positions that we put them in. Just recognize that compression could be the nerve, which is actually the most common form or the most common, form of thoracic outlet syndrome is the patient actually suffers from compression of this brachial plexus nerve versus vessel compression. So it's actually, I'm not saying it's good, but it's typically not a vascular cause or a vascular symptom when we're talking about thoracic outlet syndrome. So blue toe syndrome. So these are patients that present with either a cyanotic looking digit, so it could be the foot, could even be the hand. More commonly, it's seen in the foot, but it's a result of atheroemboli or small emboli breaking off and small plaques. I'm sorry, small atherosclerotic plaques that break off and then travel into the small, tiny vessels of either the foot or the hand. So these small little emboli, they break off, they travel distally, and then they get stuck in the small vessels, creating this condition. So we're concerned with patients that have atherosclerotic lesions. I also would worry about blue toe syndrome in patients that have maybe an abdominal aortic aneurysm. So little pieces of that thrombosed aneurysm could potentially break off and do the same condition. So if you ever get a patient, you know, they're ordering like a DVT study or a venous study, and you take their socks off or their pants off to do their test, and you notice that it's just their toe that looks cyanotic and blue like that, you can call the physician and be like, you know, I think we need an arterial exam as opposed to a venous study. So coarctation of the aorta. So this is a congenital abnormality that patients are born with. So this is typically something that we're going to diagnose in a young child or even an infant. You guys doing DMS, you might even pick something this is picked up in a fetal echocardiogram. So when they're going through their you know, scans, I don't know at what age they'd start looking at the heart in detail, right? Or no, I'm not sure. But anyway, coarctation refers to a narrowing of the thoracic aorta. So it's the descending thoracic aorta just past the level of the subclavian artery. So that's the most common location of this coarc or this narrowing. So this narrowing, if you can imagine, you know, you're crimping the aorta, pressure now is going to build up in that proximal ascending aorta. And if it's building up in this area, it's also going to build up in those branches coming off the aortic arch. So those two branches, one is the left subclavian, one is the brachiocephalic, which leads to the right subclavian. That's going to cause elevated pressures, brachial pressures in your arms. So you're going to have elevated pressures bilaterally in your upper extremities. And then conversely, on the other side of that, after this narrowing, you're going to have very low pressures going through the entire aorta, descending aorta. So you're gonna have low pressures, you know, going to your organs. You're gonna have low pressures going out to the lower extremities. So the reason why this kind of falls into vascular as well is because you could be doing a PVR SLP on a young patient who's been experiencing symptoms, and you get very low pressures all the way throughout their lower extremities, and you're like, this is kind of weird. And her brachial pressures are super high, you know, like this just kind of isn't adding up. Like, why is this poor young kid or this young patient have hypertension in the arms, but yet their legs are, you know, have very, very low pressures? So that should raise red flags for you. Like maybe we're dealing with a patient that has an undiagnosed coarctation of their aorta. To repair this, they would go in, do a balloon angioplasty, open up that coarc, place a stent in there to try and keep it open. The arteriovenous fistula.
So, Dan,
Yeah.
you would be able to see that, like, if we were at MFN and we were scanning and they did like a fetal echo, you would be able to see it?
Well, probably if they look at the aortic arch, I don't know how far they go past the outflow tracts. Like,
I know they definitely look at like the aortic arch.
yeah, so yeah, you'd be able to see that definitely. When they put their color on, like if you go back, like it's the same thing as having like a stenotic lesion. So you'll wind up with aliasing turbulent flow through that area. You can Doppler the velocities through there, you measure elevated velocities. That's what we do in echo. So when we're doing echo, I'm sure it's part of the fetal echocardiogram. It has to be 100%.
Yeah, I mean, I think
Because that's standard for adult echo when we look at the aortic arch.
Yeah.
Every exam, we look at the patient's aortic arch.
when they start doing the echoes. When? Yeah. Is that like? I want to say like, I think I'm gonna the heart. Needs to develop and then. Like 2 to 4 after the development, right? Yeah, yeah. Beautiful, Dan.
I don't see him, but anyway. I'm the worst.
Yeah. I sound the learn. Yeah.
So arteriovenous fistula. AVF. That's all right. Let me put the light on.
Yeah.
What?
Like, you know, vampires like. They're not gonna stick at me. Yeah. It was supposed to be funny. It was.
I'm an 80s child, so for me, bright light is associated with like the gremlins. Like,
Yeah, exactly.
Yeah. Bright light, bright light. So anyway, AVF. So fistula is the term fistula just refers to a connection between two systems. So in vascular, we concern ourselves with arterial venous fistulas. So a connection between the arterial system and the venous system. So this is an abnormal vascular connection. So in the normal conditions, arteries and veins should be separate. We shouldn't have, arterial blood flow going directly into the venous system. So this is an abnormal condition. We're going to see in a moment, there's a couple of different forms or types of arteriovenous fistulas. There are congenital arteriovenous fistulas that people are born with. Those are referred to as AVMs or arteriovenous malformations. But most likely, if you encounter a fistula, it's either intentional. We're doing this on purpose in order to have the patient be able to get hemodialysis or dialysis treatments, or it could be a result of some sort of trauma. Either, an accident when we inadvertently created it by introducing an arterial catheter and then maybe puncturing too far and connecting into the venous system, into the vein, or it could be through some sort of physical trauma to that patient. But regardless of what type of fistula you have, they all have the same characteristics in terms of flow patterns. So the artery now, if there's a fistula present, normally we'd expect high resistant triphasic waveforms in that artery going down towards the arm. Can you see?
Yeah.
Kind of. Did I make it worse? Kind of. There we go. For the viewers at home. So normally we'd expect in our arterial waveform, so this is artery. That arterial blood flow going down the arm. So normally, we'd expect to have, a nice triphasic waveform. That's what we'd expect. But since we have a connection of that artery being connected to the vein, all that arterial blood flow is now, or the majority of it is dumping into a very low pressure vascular system. So just always keep that in the back of your mind. Arterial characteristics, arterial waveforms get their characteristics based on where that blood flow is going. So now that arterial blood flow, a majority of it is being shunted into the low pressure venous system. Things want to go from high pressure into low pressure. So that high pressure arterial system is going to say, oh, wow, I got a nice pass of low resistance. I'm going to divert myself and go directly into this venous system. So some blood flow still continues down the arm, but the majority of it now is being siphoned off into the venous system. So the characteristics of that artery proximal or before that connection to the venous system, the waveforms change their characteristics. So now instead of having triphasic waveform, we're going to have something with elevated velocities that is monophasic, low resistant flow. So we're going to say low resistance, high velocity. Yeah.
Why does it low resistance before it goes into the thing?
Why?
I thought it was low resistance after it goes in.
So it's getting its characteristics from where it's going. So where is it going? It's going into the venous system. So it's now when it's not there, this is the high resistant vascular bed, our muscles of our our extremity. But since it's now being diverted, or a large portion of it is being diverted into that low pressure system, it's going to change that characteristic. So all this blood flow that's before it now has a nice easy pathway. So now it's able to change. That's a good question. If I was to then Doppler distal to that anastomosis, that waveform all of a sudden just reverts back to what it normally should be. So after that anastomosis, we go back to a high resistant and I'm going to say a lower velocity waveform. So we go back to a normal looking arterial waveform once we get past that anastomosis. So if I happen to be a red blood cell that got past that and I'm continuing down the arm towards the hand, my waveform characteristics now go back to where I'm supposed to be going. So we can revert back to a normal looking waveform. So the connection between the artery and vein over here is called an anastomosis. anastomosis, anastomosis. So that is the connection between the artery and the vein, that connection site or connection point. Better. So at that anastomotic site or that anastomosis site, we should be able to feel something called a palpable thrill. So this is where we're going to have the most turbulent blood flow. So I'm just going to put over here most turbulent blood flow. Highest velocities. So at that anastomotic site, we can actually feel, that's where we're feeling on the patient's arm. We can feel the actual palpable thrill. So we're gonna have to start playing our word association now. So anytime you see a question that says palpable thrill, AVF, arteriovenous fistula. When you start seeing words or a term that says pulsatile mass, that's going to be this guy, pseudoaneurysm. Where's pseudoaneurysm? There we go, pseudoaneurysm. These are pulsatile mass. So thankfully, the board's exams uses the same general descriptive terms, for all these different things.
What did you say for the other one? Yeah.
Pseudoaneurysm is palpable pulsatile mass. Palpable thrill is arteriovenous fistula. So at that anastomotic site, we're gonna have the most turbulent blood flow, the highest velocities. We should be able to feel what's called a palpable thrill. So we actually feel the vibrations of all that turbulent flow. It's gonna be low resistance. Absolutely. Low resistance. Trying to think what other descriptive terms. And then, so that arterial blood flow, crosses over into the venous system. So now this is a vein. So maybe it's cephalic vein if it's an intentional AVF. Could be basilic vein. Again, if it's intentional. If it's unintentional, this could be a deep vein. But anyway, so that arterial blood flow crosses now into the venous system. And that venous blood flow now is returning back up the arm. But now that venous blood flow, since it now has arterial blood flow mixing into it, also has very different flow patterns. So normally venous flow should be nice and phasic, following our respiratory variations. We should get nice rolling waves. But now that we have all this arterialized blood dumping directly into it, we now have in that outflow vein what's referred to as mixed arterialized arterialized. I spell artery. There we go. Brian, we can have in my head. Arterialized blood flow. So you can actually see it has some venous characteristics, and then it also has arterial characteristics. So we see pulsations. We actually could see a pulse in the venous system now, which we shouldn't expect to see. Like, we shouldn't be able to pick up those pulsations. So this bottom image, gonna move us back. So this is that outflow vein. So we can see that it looks, the direction is telling me it's vein. We got some mixing of venous signals in there, but we can obviously see arterial pulsations in it as well. So that's a mixed signal in that outflow vein. When we're talking about arteriovenous fistulas, we worry about, particularly when it's diabetic patients, the development of stenosis or narrowing, particularly at the venous anastomosis sites, as well as that venous outflow vein. We can wind up with narrowing. So that's not good when we have patients that are trying to do hemodialysis, and we have to maintain certain flow volumes in that fistula. We also worry about pseudoaneurysm formation, particularly with hemodialysis patients, because we're repeatedly puncturing this outflow vein. So once we do dialysis now, so if it's intentional, we're doing this for hemodialysis, we're going to create this fistula. We're going to give it time, what's called to mature. So it takes a while for this vein to kind of enlarge and be able to handle and accommodate these increased flow volumes. So the flow volumes in that vein are going to go up and up and up until they reach a point of maturity. So we're going to get a little more in detail when we talk about fistulas, but eventually they're just going to be accessing that outflow vein every time they do dialysis. They're going to put one catheter here and another catheter further up. So they'll draw the patient's blood out, spin it, dialyze it, filter it out, and then return it back into the patient in that more distal or more proximal catheter further up the arm. So like I said, there are three main types of arteriovenous fistulas. So congenital. So this is something patients born with. This is referred to as an arteriovenous malformation. So may present with many small communications within a mass of tissue. So this could be located, pretty much anywhere throughout the body, arteriovenous malformation. I think there was one student that their child had an AVM like on the tissue of their lip, and it was like they were trying to treat it and they weren't too sure what it was. Traumatic. So this is they most commonly have a single connection with a dilation of the proximal arterial system. So traumatic AVF is usually a complication, like I said, of some sort of invasive arterial procedure. Or if it could be intentional when we want to create access for dialysis. Another thing with traumatic, so maybe you guys might actually see this. Sometimes I've had a couple pelvic exams where I've done where like I put color on, and I've seen what look like areas of like turbulent flow within the uterus, and it was probably a result of like the woman's C-section, and they maybe when they were doing the C-section they cut an artery and nicked a vein and then actually created a fistula within the myometrial tissue, that patient's uterus. So that is a potential, complication of C-section. So this is just showing some images. So you can see very turbulent flow. We have no spectral window at all. Everything's filled in. Velocities are very, very fast. So this is the arterial flow just before that AVF, just before the fistula. This is now arterial flow distal to that fistula. So it returns back to a normal looking, triphasic, high resistant flow pattern. Something that can potentially occur in the flow once we get past that fistula or distal to that fistula, some patients might experience, I'm gonna go back to this steal phenomenon. So I know you're dying.
No, I was wondering what the third one is.
Which one?
I was trying to catch it when you were.
Oh, the third one?
Yeah, no, the one above. Yeah, access dialysis.
Hemodialysis access. So this is patients that need diet. Yeah, so patients need, these are patients that have end stage renal disease, their kidneys aren't functioning. So we have to now filter their blood for them. So they go to dialysis. So that I want to maybe take you guys down to the actual dialysis center at some point to just see, what it all entails. I don't know, has anyone actually seen dialysis? No. So I honestly feel really bad for these patients, it sucks, man. Once you have to go on dialysis, it's like 2 days out of the week, and then you're there for like 3-4 hours and like hooked up to this machine, and yeah, it sucks. So this was just talking about some of the different procedures that they would do for dialysis access. So this first is fistula is the most common, but we'll go into that a little more detail. Hello. Hey, how are you doing? I'm good. I'm just in the middle of vascular class, but what's going on? I'm sorry? Okay, all right. Yeah, I'll give you a call back later. All right, I saw you pass all your boards. Congratulations. Good job, my friend. All right. All right, take care. Bye. God will.
Nice.
Yeah. Okay, he took all three. A couple of them took all three. Devin took all three. He took all three.
I saw Devin and Sulema at
Yeah.
NFM.
I gotta get on Sulema. I think she's only taken OBGYN so far. But I mean, she's working there. But
Yeah.
yeah.
Word.
She's nice. She's super good.
Yeah.
All right. So I was saying was potentially patients can wind up with a steal phenomenon. So what this referred to is blood flow actually going in the wrong direction. So retrograde flow or reversal of blood flow in that segment that we're imaging. So what could happen sometimes is this fistula, this connection is too large, it's too powerful, and it's drawing up too much blood flow into that fistula into the venous system, that it actually acts like a suction in a vacuum and draws the blood flow back up the arm. So now blood flow isn't getting down towards the hand, and we actually wind up with flow reversal in that segment that's past that fistula. So a little bit past it, sometimes if you Doppler just immediately past it, you can get reverse flow. But if you continue further down the arm and you're still seeing flow reversal going in the wrong direction, that's not good. That could potentially lead to cyanosis of the hand, depending on how severe it is. So it really goes based on patient's symptoms.
Man, that's supposed to be a hand.
Yeah, it's supposed to be a hand.
Oh my gosh. What did you think it was? I wasn't sure.
Oh. I wasn't sure what it was supposed to be. Telling you, your kids could draw better than me. Your daughter's a good artist, right? Isn't she?
She's pretty good.
Yeah.
You're better than that.
True. Yeah, I never get picked for Pictionary. Damn it, Dad, what are you trying to draw? This isn't even close. All right, so this is a case study where there was an AVF, a fistula between the superficial femoral artery and the femoral vein. So here we can see the SFA coursing anterior to the femoral vein. And we see an area of very fast turbulent flow, so area of aliasing between that artery and the vein. So that indicates, the possible presence of a fistula. And when they Dopplered it, they got very turbulent flow, very fast velocities. So that's something when we get into doing our arterial imaging or even our venous imaging, when you see abnormal looking waveforms from what you would expect, you then have to go in back and try and figure out like what could be causing that abnormal waveform that we're seeing, and then try and find the potential location of that disease. So in this case, if I was doing an arterial exam, working my way down the leg and I'm Doppling, I'm getting low resistant flow, I'm like, that's kind of weird, the vessel looks open and patent. I don't see any plaque, I don't see anything going on, low resistant flow. And then I get a little further, and then all of a sudden it's high resistant again. I'm like, something is going on in that proximal segment to cause that low resistant flow. So then it's my job to go back and try and find that actual location of that stenosis. I would also notice changes in the venous system as well. Say, for instance, I'm actually doing a DVT study, and I start in the common femoral vein, and I see very fast velocities that look very pulsatile. I see arterial pulsations in it. That's not a normal thing. So that automatically in my mind, I'm like, all right, dude, this guy's got a fistula, so I got to go back and I got to find this. Something's causing these very fast velocities, this turbulent flow in the venous system. This was another example, lower extremity study, a patient that had a fistula between the profunda or the deep femoral artery and the SFV. So in this case, they're just showing a color picture showing the two vessels, our superficial femoral artery and our deep femoral artery. And then during the cardiac cycle, that deep femoral artery has continuous flow, indicating that it's low resistance, whereas this one has a triphasic flow. We get a period where there's no flow in it. And then when they did the actual Doppler waveforms, they could see the stark difference between the two flow patterns. So this shouldn't be like this. Like these two arteries should have very similar looking flow patterns, particularly when you don't see any sort of calcific disease, you don't see any atherosclerosis. That top one is a normal flow pattern, high resistant, triphasic. That bottom one is very low resistant with elevated velocities. So this one is the one that has the fistula involvement. So they were able to discover the fistula between the profunda and the femoral vein. So they're kind of fishing around, looking around in here, trying to find that connection. So when they were able to actually locate the site of that connection, that's when they are demonstrating their maximum velocities with the turbulent flow. So common types of dialysis grafts and surgical placements. So when surgeons or doctors want to do fistula for hemodialysis purposes, they're going to connect an artery to a superficial vein. The site that they like to go to ideally is this radial artery to cephalic vein down by the wrist, just because those two vessels are in close proximity to each other. They're easy to attach together. And they also create a nice outflow vein. That cephalic vein is fairly close to the surface of the skin in the forearm, so it's easy to access. So that's a nice site, but that type of fistula is referred to as a fascica seminofistula. It's a side-to-side connection between the radial artery and cephalic vein. This is referred to also as an autogenous fistula, meaning it's using the vessels that are native to that person's body. So if a patient has peripheral arterial disease, or if they have disease segments, or if their vessels aren't large enough in diameter, the doctors or surgeons might have to put in synthetic material and connect one end to the artery and another end to the vein. And if they use the synthetic material, those are often referred to as grafts, or AVGs, arteriovenous grafts. This is just showing that fascica semino fistula. How that artery connects side to side with the vein. So arterial blood flow coming down, goes into the venous system and then back up the vein. And typically, yeah.
That's a good question, but why do they connect it to their dialysis?
So the dialysis machine, in order to operate, needs very large volumes of blood flow. So you need a high flow volume. And in order to be able to have a sufficient flow volume, it just doesn't exist in the arteries. So the amount of blood flow that's in your peripheral arteries, like you can see, like it's high resistant flow. So during that diastolic period, there's not much blood flow getting through. So we have to create an environment where we have continuous high flow volumes. Our venous system too, the amount of blood flow that just is in our venous system isn't fast enough or large enough. So we have to create a roaring river to get the blood flow out of the patient fast into the machine to dialyze and then back in. It's a large volume of blood that needs to just get moving and circulating. So they came up with this idea of creating these fistulas in order to do that. Don't ask me who thought of this, or because this isn't a normal condition. Like I can't tell you how many patients come to me just after surgery, after they create the fistula and their veins are starting to swell up and they're like, my arm is killing me, it hurts. I'm like, no kidding. This isn't a natural thing we just did to you. Like all this pressure now is coming into your venous system. Your veins are like, holy God, like all this blood flow now flowing in. They become large, they become very dilated. I've seen huge veins like oozing, like aneurysmal, like they look like eyeballs like bulging on this patient's arm, like it's gross. But yeah, they can become very aneurysmal as the veins start to dilate and stretch. So yeah, we need a very high flow volume in here. So the flow volumes are going to be about 1,000 milliliters per second, or a liter per second. So that's a huge amount of blood flow that's circulating through that vein at that time.
Do they unconnect it once they get off the dialysis?
No, the fistula stays permanent. So they want to keep this and maintain this. This is the patient's lifeline until they get a kidney transplant. So they want to preserve this at all costs. That's why you never take a blood pressure on a patient that has a fistula in that arm. You don't want to do anything to disrupt this. They don't do IVs, they don't do blood draws, they don't touch that arm. So this is what's keeping that patient alive. So when that fistula fails, they got to come up with another procedure, do a revision, another fistula, maybe a temporary one, try the other arm. And when they do fail, they just kind of leave them in there, especially the synthetic ones. I've seen plenty of the synthetic fistulas like this. They actually use Gore-Tex material. So you think your waterproof like sneakers or jacket or shoes or whatever that has Gore-Tex in it. These synthetic grafts are actually made out of that same material, the Gore-Tex. So these grafts are referred to as AVGs, arteriovenous grafts, using the synthetic material. So with this, there's two ends now. There's two anastomotic sites. So we have an arterial anastomosis site, where the graft, synthetic material, connects to the artery. So this is a loop graft. It then loops around and then connects to the venous side, the venous outflow. So this is most of the times they like to use a forearm loop graft that connects maybe brachial artery around to either basilic vein or maybe around to the cephalic vein. This is a straight graft now, so this goes directly brachial artery up to the cephalic, up to the basilic vein on this side. They could potentially connect it to the cephalic vein. So we'll go more into the protocol for imaging these next semester. So physical exam. So when we were doing our PVR SLP comp, you know, we would do our physical exam, we'd ask our questions, but we're also doing a visual physical exam for our patients as well. So patients with peripheral arterial disease, we notice certain skin color changes. So primarily pallor or paleness, loss of color, as well as cyanosis, so purplish discoloration that indicates, you know, reduced blood flow. Patients can also have rhubarb or redness, particularly when we talk about elevation pallor. So when they raise their legs up, they lose they're getting poor blood flow down to their extremities. So they turn very, very pale. But when they lower their legs down, all of a sudden they get a surge of blood going back down, and they result in sudden redness or rhubarb to their skin. You might notice temperature changes in the skin. So you could feel the patient's legs, they feel very, very cold to the touch, cool to the touch. The lesions or ulcers that are associated with arterial are very deep. They typically have regular smooth borders to them. And they're also very, very painful. So arterial ulcers are very painful. They're very deep. They're along the bony prominences. We can also see some various trophic changes or additional changes to the extremities that we might notice, like thickened toenails, shiny, scaly skin, loss of hair, particularly on the shins. We talked about palpating, so feeling for pulses. We can also potentially listen. So this is maybe not as common for us, maybe more a physician or a PA or doctor will actually be listening to the arteries. So they might be able to hear an audible bruit. So that bruit is the audible sound that's created by turbulent flow. So it's abnormal low frequency sound caused by a significant stenosis or blockage that causes a vibratory response on the tissue. It's more common for doctors to listen for bruits when they're listening to the carotid arteries in the neck, as well as maybe the abdominal aorta. It's a little less common for the legs. This is just showing some specific sites where you could potentially feel for pulses. So we know radial, we know ulnar, and just on the other side, brachial pulse. You can even feel for subclavian pulse above the clavicle. Carotid pulse, which is probably the most common when you're feeling for the pulse in the neck. I could feel for a superficial temporal artery pulse. Also feel for pulses in the legs. So up in the groin, common femoral artery behind the knee, popliteal. We know posterior tibial dorsalis pedis pulses. So now I'm just going to talk a little bit about some interventions for arterial disease. What are the four main risk factors for peripheral arterial disease? The four biggies.
Diabetes.
Smoking, diabetes.
High cholesterol.
Yes. Hypertension. So hyperlipidemia, hypertension, diabetes, and smoking. So those are your biggies. So since those are the main ones, all of those are controllable. So the main course of or one of the primary courses of treatment is correct and conservative treatment is cessation or correction of all those conditions. You know, so if you have high cholesterol, change your diet, take cholesterol meds. Hypertension, then exercise, take blood pressure meds, quit smoking. If you're diabetic, control your blood sugars, diet, exercise, lose weight. So all those things will help and are considered conservative treatments. If those don't work, might be in conjunction with medical treatments like aspirin, blood thinners. Percentine helps to is a antiplatelet drug. Maybe vasodilators to expand your vessels. But if you have to be a little more aggressive and the disease has really progressed, you might wind up with surgical interventions. So surgical interventions, this is when the patient actually has to go into the OR to surgery under anesthesia, they get put out. So this could involve, putting in a bypass graft. Endarterectomy is the surgical removal of plaque. So this is very, very common, or not very common, but this is commonly done with the carotid arteries in the neck. They go up to the OR. They actually cut open the patient's internal carotid artery and common carotid artery where the plaque is, surgically remove the plaque, and then sew the patient's carotid artery back up. So they're actually on a bypass machine to get blood flow, around the area that they're working. So there's still blood flow going to the brain. Might have to amputate areas that become gangrenous or necrotic. Sympathectomy is a nerve block, so we might actually have to administer maybe some sort of nerve block. When we're talking about some of those vasospastic disorders, or if the muscle or the blood vessels are spasming up on you, they might introduce a nerve block to prevent that from happening. Non-surgical interventions, even though you think, this seems pretty invasive, these procedures are done, the patient's still awake, so it'd be done more in the cath lab. Still a sterile procedure, so you need to still maintain a sterile field and all that. But the patients are typically still awake for them, so they don't necessarily have to go into the actual OR. There it is. So those include angioplasty. We're gonna go a little more in detail. Angioplasty, atherectomy, vascular stents. What?
I know US does it. You don't know what I would do. Just gotta turn my laptop.
That's all right. It's a different perspective. You're hiding behind this thing. I lose you. Like, I don't even see you just because my eye level is so damn low. All right, so surgical intervention, bypass grafts. So we're talking about the legs, most common location for peripheral arterial disease. Patients got crappy arterial flow in their legs. We need to get blood flow down to the foot. So patients got disease in their arteries, we got to get blood flow down the leg. Doctors decide, all right, we got to do a bypass graft. So they have a couple of options. They can use a synthetic graft, so that Gore-Tex material, to connect to a segment of the artery that's healthy and okay, and then use that synthetic graft as a conduit or channel to get blood flow past whatever blockage exists down and connect it down to an artery further down to get blood flow down the leg. We could also use our native vessels. So we said that our GSV, that great saphenous vein, is commonly used for bypass surgery. So when we're talking about the legs, we would utilize that GSV, and doctors have actually two options. So they can do either a reversed vein graft or an in situ vein graft. So this reverse vein graft, what they're doing is they're actually taking the GSV out of the patient and then flipping it upside down and then reconnecting it. So they connect one end to the artery up here and the other end to the artery lower down. Any idea why they would reverse it? Flip it.
Wait,
Yep.
explain it.
Yeah, that's fine. I'm gonna draw my ugly leg. There's my blue. Okay, so we've got an artery coming down the leg. There's an area that's blocked, so we'll put a blockage here. Patient also has their great saphenous vein, running down the entire leg as well. So that GSV, they can take, a piece of that GSV and use it as a graft. So they have two options when they want to take that GSV, so they can take it. And they can just leave it in its location, attach it to that artery up here. Goes down the leg, and then they can reattach it, over here to get past that blockage. So now there's, in that GSV now, there's arterialized blood flow. So blood flow from that artery is coming into that vein graft, getting past the blockage and then reconnecting, and we're good. Now we got blood flow going down the leg. So if they leave it in its normal anatomical position, that's referred to as an in situ saphenous vein graft or in situ vein graft. So they leave it in sight. They don't remove it. They just kind of connect it to the artery here, connect it to the artery there. So I'm just gonna put in situ vein graft. Vein is in, I want to say, should we say normal anatomical position or left in the same position? Now, what words could we use? Same position. Vein in same position
As usual.
as usual. So you have to think now. So we left this vein in the same position. So normally venous blood flow is going up the leg. And the GSV particularly has those little valves in it to prevent blood flow from going back down the leg. But we want blood flow to go down the leg because it's an artery now. So those valves are going to impede the blood flow going down that vessel. So if we leave it in situ, we have to disrupt those valves. So we have to go in there and actually the surgeon has to destroy those valves. Maybe they'll use some sclerosing agent, some saline, maybe to destroy the valves, or they'll actually surgically destroy the valves. In order to allow blood flow to travel down that vessel now as an artery. They also have to tie off those perforators as well. So they tie off the perforators, disrupt those valves to allow the blood flow to go down that leg. That seems like a big deal, like why would they want to go through all that trouble to do that? But the benefits of the in situ graft, so benefit is size. I'm going to say attachment size matching. Attachment size matching. So what that means is our great saphenous vein, more proximal, is larger in diameter, and as we work our way down, it gets smaller in diameter. So when we take that GSV and leave it in its place, we have a large end up here connecting to a larger artery up here. And then we have a smaller end connecting to a smaller artery down there. So that's good size matching. So we don't worry about that. So that's the benefit of doing this. But we have to go in and disrupt those valves. But if we don't want to go in there and disrupt those valves and tie off the perforators, doctors would then take that GSV, flip it upside down now. So those valves are now inconsequential. They're not affecting the blood flow. So if we do a reverse vein graft, we don't have to disrupt those valves because they're not working against us. The blood flow can still go through, no problem. But the problem with that is we now have a size mismatch. So that's the disadvantage of this. We now have a small piece of vein connecting to a larger artery up here. And then that small piece of vein connecting to that larger artery, and then that large vein trying to connect to a much smaller artery low down. So that might make the surgery much more challenging, a lot more difficult, particularly if you're trying to connect that larger saphenous vein to a very small posterior tibial artery vein, or maybe even something on top of the foot, dorsal pedis artery, or whatever the surgeon's trying to do. So the reverse vein graft has a size mismatch, but the valves aren't an issue. With the in situ, the valves are an issue, but we have good size matching.
So
It's up to the doctors to decide.
I don't understand, like, why would they?
It all
I
depends.
feel like the inside tube would be like the easiest, and it would make more sense. I guess. But then you'd have to, remove the valves for that?
Yeah, you'd have to disrupt the valves. Maybe it depends on the length of the segment that they have to I should ask the doctor why they one versus the other, you know?
Does one take longer than the other?
Probably, I don't know.
I guess it really just.
This is just showing some, various bypass graphs. So this is, patient's abdominal aorta. So maybe they have a aortic aneurysm or a disease segment that's highly stenotic, and we need to get blood flow. So when we get into abdominal vasculature, we're going to talk in detail about these graphs, these arterial graphs when as it relates to the aorta. So I'm not going to go into too much detail, you know, right now about these. But that last one, D, represents what they more commonly do now with an endograph, where they actually put the graft within the actual aortic vessel. So you see the graft coursing within the actual aorta. All right. Endarterectomy. So this is the surgical removal of plaque now. So we're going to see in a moment, we have atherectomy, which is a non-surgical removal of plaque where they scrape out and remove the plaque. But this involves surgery. So they're actually surgically cutting open the vessel and surgically removing that plaque. Typically done in the patients for the carotid arteries, the ICA and the proximal carotid artery. So you can see they clamped off the vessel, cut it open, surgically remove the plaque. There's some instances where they actually have to put in a patch over that vessel now, where they actually, because sometimes they also take a piece of that intimal lining as well. And when they close it up, they want to open up that vessel a little bit more. They'll put in a patch to keep it wider. So those were some surgical interventions, the bypass grafts, endarterectomy. Non-surgical now, so these are non-surgical interventions. So this is angioplasty or balloon angioplasty. So this is one of the questions that we were asking on our PVRSLP exam. So this involves introducing a catheter typically into the patient's groin, into the femoral artery, running that catheter to the area of stenosis or blockage. And then on the tip of that catheter is a balloon that's able to inflate and deflate. So they inflate and deflate this balloon multiple times and actually just kind of smushes the atherosclerotic plaque up against the wall to try and open up that vessel and allow for better blood flow through it. So this is just showing, you know, area of plaque. We can bring the catheter to that area of plaque, and then we inflate and deflate that balloon multiple times. Remove the catheter, and that plaque is now smushed up against the wall and helps to allow for more normal blood flow in that segment of vessel. So this is balloon angioplasty. These are just some of the various different catheter sizes and tips. Another non-surgical procedure is something called an embolectomy. So this would be done more if a patient has acute onset of symptoms, because this is a soft blood clot that's now lodged in the vessel. So with this, we're actually able to puncture through that soft clot, go past it, and then inflate the balloon and kind of withdraw the catheter now, and it pulls that blood clot with it. So this would be someone that has an acute arterial occlusion or blockage. So maybe they had a clot from their heart that got ejected into the aorta down the leg, and now it's getting lodged in their popliteal artery. They have all sort of pain in their calf, their legs starting to turn blue, or their foot starting to turn blue. You know, it's an acute symptom. So this is still soft in nature. They can puncture through it, inflate that balloon, and then when they withdraw the catheter, it pulls that clot with it to remove that embolus. Embolectomy. Then we can also perform an atherectomy. So this is the removal of atherosclerotic plaque. So this is non-surgical still. So with this, the catheter tip is specially designed. So I kind of think of this almost like as a cheese grater that spins, grinds up the plaque. And there's a suction on the catheter as well to draw up that plaque that's now being kind of cheese grated and ground up. And it's sucked into that catheter tip through vacuum suction. So none of that atherosclerotic plaque that you've now broken up travels and embolizes down the leg. It all gets caught up in that catheter tip and then it's removed. This is an atherectomy. We can even use lasers now to perform atherectomy to burn some of that plaque up. So we've gone into the patient's, groin, we've introduced that catheter, we've done all the work to try and either open it up with maybe balloon angioplasty or an atherectomy. The doctors might also now at that point decide they want to put a vascular stent in. So we've done all this work. Let's try and keep that vessel open as long as possible. Because you have to remember a lot of the same disease processes that cause that initial stenosis are going to cause that vessel to restenose. So maybe they'll decide to put a stent in to try and elongate that time period between maybe having to do that intervention again. This is particularly true when we're talking about critical arteries, maybe like renal artery stenosis, or superior mesenteric artery, some of the vasculature going to vessels. Carotid arteries, absolutely, they love to stent open carotid arteries, those are critical. The good thing about vascular stents is they're very discernible. You can pick them up easily on ultrasound from your native vessel wall. So you can see obviously where that stent is appearing. The stent walls appear very bright, very echogenic. You can see the studding of the stents, so you can see the little studs in the stent. If you kind of angle kind of oblique on it, you can actually pick up the ribbing or the mesh of that stent. If you angle slightly oblique on it, transverse, they're very obvious in transverse as well. They're very echogenic. You can see the echogenic ring around it, the little dots as well. Sometimes the stents can also be drug coated as well. So they might put in either anticoagulating medications in the stent. So you can see they're very, very small. This is a pencil tip compared to a pencil, Pseudoaneurysm. All right, so a pseudoaneurysm, we said was a type of aneurysm. We call it a false aneurysm. This is a typically result of some sort of interventional procedure gone awry. So patient's gone to the cardiac cath lab. They went into the groin, punctured the artery to do whatever procedure they need. They finished the procedure. They're removing the catheter. Maybe they removed it too quickly. Maybe they didn't hold enough pressure after the procedure to close off that artery. And the patient is still bleeding out of that artery. The body kind of encapsulates it to prevent that blood flow from going everywhere. So what happens is we get a hematoma that's vascular, it's bleeding, there's blood flow in this hematoma or active bleed within this hematoma. What happens is during that cardiac cycle, or blood flow exits out of the vessel through a neck into this hematoma where it's bleeding, goes in, swirls around, and then exits back out of the neck during diastole. So we get a very telltale Doppler signal with patients that have a pseudoaneurysm. It's a very distinctive bidirectional flow pattern that we pick up when we're Dopplering the neck. So this is the hematoma. The hematoma could be partially thrombosed, so maybe they were holding pressure. Part of this became clotted off. Some of it some of it's still actively bleeding. So in patients that have a known pseudoaneurysm, under ultrasound guidance, they might actually try to hold compression on this hematoma to completely thrombose it. So we'll be imaging with ultrasound to find out exactly where it is. We'll hold the probe over it, and then someone else or a doctor might hold manual pressure over this manual compression to try and completely thrombose this hematoma. So once this becomes all clotted, that's going to close off the neck and close off this artery. So that's the goal of this manual compression. That depends on the size and location of the pseudoaneurysm, the size of that neck. It all kind of dictates which procedure they do. The other option is to inject a medication called thrombin or do a thrombin injection. So thrombin is a medication that will clot blood basically instantly. They put a little needle into this actual hematoma and they inject thrombin medication. So this is also done under ultrasound guidance. So you guys will get involved. Have any of you actually seen a thrombin injection? No. No. I wonder if they do it in the general lab or if it's vascular. There you go. So this is the patient's native artery. This is that hematoma. You can see color flow in it. Another thing about pseudoaneurysms with hematoma, they typically have this yin yang appearance to the blood flow because it's going in, swelling around, and coming back around. So it creates this yin yang pattern. But the doctors under ultrasound guidance will introduce their needle with that thrombin medication into the hematoma. Inject the medication. With your color on, you're still imaging, and it's going to thrombose instantly. I know the boards asked a couple of years ago about proper needle placement for injecting a pseudoaneurysm, where you place that needle. So it was multiple choice. So they gave a couple options. One of them was like in the neck of the pseudoaneurysm. One was like inferior, close to the neck. That needle placement, you want to be as far away from that neck as possible. So you want to be in the, the most superficial portion, as far away from the neck as possible when you're injecting that medication. Because that medication, it clots blood instantly. If you're close to that neck and you get medication into that native artery, you're in a world of trouble. You're now going to thrombose that patient's leg. So you don't want to get any of that clotting medication, or small amounts maybe do eventually get in, but you don't want to be anywhere near the neck or anywhere near the base of that hematoma close to that neck. You want that needle as far away from that neck as possible because you don't want any of that clotting medication getting into that native artery. So this is showing the thrombin injection before and after. So before you could see, actively bleeding, and then after they initially inject the thrombin medication, thrombosis completely, and that native artery is still underneath it. This was just showing now some the technologist Dopplering the neck of that pseudoaneurysm. So it's that very distinctive bidirectional flow. So during systole, you get forward flow and then a quick reversal during diastole. So that neck flow, I definitely want you guys to be able to leave this class, be able to recognize that flow during in a pseudoaneurysm. So it's bidirectional to and fro flow in the neck. That's a very distinctive sound too. It's like because the velocities are very fast. Another procedure is called embolization, or you might hear it referred to as coil embolization or coiling. So embolization is when we try and close off a vessel in order to stop a bleed. So patients who have a stroke, they're bleeding in their brain, they'll go into the vessel that's bleeding and perform an embolization to try and either using either a substance or a mechanical device or chemical material to occlude or drastically reduce blood flow within that vessel. So we do it to try and control bleeding, or maybe a GI bleed, vessels bleeding in the gastrointestinal tract, or definitely in the brain. Can be used to reduce blood flow to a tumor. So they want to maybe resect a cancerous tumor. They want to try and shrink the size of that tumor. They'll embolize the feeding vessel to that tumor. So that's embolization. So ultrasound is good for follow-up. Our duplex scanners can be brought into the operating room to increase the quality and specificity of a procedure by detecting any abnormalities. At the end of the operation, can be used for serial follow-up after we've done any of these interventional procedures. That was week 4. Week 5 is the lab, which we've already done. And that's the rest of week 4. (10:30). Brain's gonna explode.
Yeah.
Yep.
I feel like it's
Pseudo explosion. I like pseudo aneurysms. It's an easy exam, an easy check. All in the groin. Yeah, so with this pseudo aneurysm study, you're gonna measure the hematoma in sagittal, so you're gonna measure the size of that hematoma. Some places, if it's starting to be thrombosed and clotted, they might have you take 2 measurements. The actual whole hematoma itself, and then the part that's still actively bleeding. So there might be a proportion like that. You'll do your sagittal measurements, transverse measurements. They want to know how large it is. More important than the actual measurement of the hematoma are your neck measurements. So with the pseudoaneurysm, you're going to measure hematoma. You're going to measure. Oh my God. Uh-oh. Measure diameter and length of neck. So this is pretty tricky oftentimes, measuring the diameter of that neck, because you really don't see it too well without having your color on. If your color, so you're going to measure the diameter of the neck, they want to know how wide it is, and then the length of it, how far away it is from that native vessel. So some pseudoaneurysms, they're located maybe way off here, and they've got a long, thin neck that goes out to it. That's great. That's perfect. That's what we would love to inject every day. Some of them are going to be very close to the native vessel and have a wider neck. So if your color gain's too high, you might overestimate the width of that neck. So you just have to be careful with your color gain as well. But those measurements are very critical in terms of dictating what procedure they're going to do, whether they inject the thrombin medication versus doing manual compression. If the neck is too wide, there's too much of a risk for that clotting medication to work its way into the native artery. So it becomes too risky of a procedure if the neck is too wide or too short. So another thing after the procedure, so post-injection, you're also gonna take some images and Doppler that native artery underneath or past the hematoma to ensure that you haven't clotted anything more distally. So you'll just take an image, showing that there's still blood flow getting down the leg immediately after that procedure as well. You don't need words to explain. PVR waveforms. I'm tired.
The dad. That goes. No, God, no. Literally never.
Ooh,
Danny Tanner. Wait,
didn't he died
yeah.
on the side here.
Mhm.
Was he really?
Mhm.
That's terrible. This time I thought it was Uncle Jesse. No, Joey. Jesse, John Stamos is John Stamos. It's like, he's 12.
First married to him, which I don't know if he's married. Joey's a perv too.
I don't know. I always pictured him probably being the one. But Bob Saget had like major drug problems when he was younger. Like,
Really? I
yeah,
didn't know that.
he was a comedian. Well, they were all comedians, I guess, all except for John Stamos. But
These weird things with a doll that looked like
oh god,
the twins. Did you hear what I just said? Yeah. He was the one that talked about it on a podcast. He brought it up. Yeah. He told the story. And then he died. I'm not saying it's karma, but I'm not saying it's karma. Okay, so. Should I, there's this lady asking about the puppies. But she's like asking if we'll have another litter. Should I be like, I'm not a breeder? Or should I say you're gonna have another litter in about 2 years when I can buy one from you? I'm never doing this again. Never doing this again. Or should I say, girl, this was an accident and yeah, I would be like, this was an accident. Wasn't planned. And then she's not gonna wanna pay like full price, do you think? Cause I'm not like an experienced breeder. Well, why is she asking if you're having more? This is what she said.
do they have 4 legs? Do they have a tail? You did your job.
Right, like, that's so
Like, what
pure-
experience?
they're so
The
pure.
dogs did all the work.
You took care of them, you got their shots, you took care of them, and like, you don't
Yeah.
pay for that. Cause she's asking, she said, I told her the price, and she said, I can't convince my husband to spend that much right now. If you end up dropping the price, please let me know. They're adorable. If you think you will have another litter, have a great day.
Just like that.
Yeah, no, not planning on it right now. This will still. God, I took him to the vet last week. It was $1,500.
Oh my god.
The hell are you getting this funny?
Huh?
I'm sorry, like that's nuts, man. My wife would. Yeah, dude.
They're going through a whole Samsung bag of dog food like every 4 days.
So yeah, sorry you can't lower the price.
Yeah, I'm just like, help, I'm poor.
That's so funny.
So it's been fun.
How much would she at, or how much were you asking for it?
So we got ours for like 1,500. And well, so the blue merles, we got them for 1,500. And then our girl Willow, the red merle, we got her for 12. And that was like, you know, like in the past few years. So we've set them like at that price, but obviously like people that we know were like, we would rather them go to you, so. And then like, you know, we dropped the price like way crazy for Cadia and then my family.
Yeah.
So I dropped the price on it.
Ah. All right,
We don't have to do this, Dan.
we don't have to, yeah, we do have
Talk
to.
about puppies more.
How many slides is this one, Dan?
Enough.
Almost.
Yeah, we have to knock off some of this, because then we're gonna get super behind.
You don't have to do the whole thing, do you?
No, we don't.
I would try.
And we'll move the quiz. Figure something out. God,
Or.
dear Lord. Bless you. Hundreds. Hundreds of thousands. Thanks.
I
Trust
don't
God.
even know about randoms. I don't even know anything about it. Yes, everything there is to know.
Start crossing some off.
Yeah.
I know this.
Oh, I know
That's
that.
not important.
Alright, guys, there's 159.
So how many are we doing
Six left on
today?
the other one.
How many are we doing
I need
today?
to know to get.
It's not like we can drink coffee, Dan. I don't wanna eat ants today.
We should have brought in margarita.
Use the other ones.
True.
Oh, man.
It's not allowed.
No.
Truly is.
Not it.
What if we get you
You
on?
don't know it wasn't a private class.
But you guys all start looking at me like.
First week.
Vomiting.
Start slurring your questions.
Then I have to fall asleep. Do that.
Why did we do that first today?
Cause I want to get through this. I know we gotta do lab. I was, Brian said he was gonna come and then he backed out. Now I'm trying to get Sydney to come.
We're not good.
There's an odd number.
Yeah.
I know, there's me, but I gotta to help you.
Alright, I'll observe.
Observe today. Sit this one out. All right. Non-invasive arterial tests. So we did one already. So these are referred to oftentimes as physiologic tests. They're indirect, non-imaging tests. So that term indirect imaging refers to a type of exam where we don't get actual physical images of whatever it is we're testing. So we can get physiologic information to determine the presence or absence of disease, but we are not able to actually pinpoint the exact location of this disease. So that was kind of the benefit of the PVR SLP exam. We could tell right away, yes or no, the patient has peripheral arterial disease. We can kind of get a general idea of where that disease could be. We can kind of tell how severe that disease, a general idea of how severe that disease is. But in terms of putting like quantitative numbers and values to it, you know, that we can't really do. And we can't pinpoint the exact location of that disease. So again, diagnoses tend to be kind of generalized. We say mild, moderate, severe. You know, we don't actually give a percentage in terms of like degree of stenosis or degree of narrowing. We talked about the different lower extremity arterial segments, the boards, and some of the literature likes to break it down into a couple of different segments. So we say aortoiliac inflow system. So that's aorta, common iliac, external iliac. Once you get past the iliacs into the groin, then this is referred to as the outflow system, the femoral popliteal outflow system. So sometimes you'll see board questions referring to inflow disease. That would be disease in the aortoiliac disease. Outflow disease would be anything basically from in the thigh down to the popliteal. And then small vessel disease or tibial runoff disease is the calf vessels. So into the leg or into the groin, out through the leg or out to the foot. It's kind of the way I kind of remember it a little bit. So these are some of the very a couple non-invasive physiologic non-imaging tests that we perform. So plethysmography, that's what we did. Segmental limb pressures we did. The treadmill exercise stress test is basically a modified version of our SLP exam where we're just getting the ABIs when we exercise and stress them. And this reactive hyperemia test we'll see is a substitute for that exercise stress test that patients with patients who can't ambulate or walk. But we're going to go into all these in a little more detail. Plethysmography. So just the term plethysmography refers to measuring volume changes in the extremities. So this is that pulse volume recording, that first part of the exam that we did, where we inflated the cuffs, and then our pulse displaces some of the air in that cuff and measures volume changes during the cardiac cycle, and we get our tracings. It can be used to detect the presence or absence of arterial disease. We can differentiate true claudication from non-vascular sources. We can kind of localize the levels of obstruction based on the changes in our waveforms. So some of the limitations for plethysmography is it's not specific to a single vessel. So meaning like, you know, if I get abnormal waveforms, you know, in my calf or my ankle cuff, I don't know if it's the posterior tibial artery. I don't know if it's the anterior tibial artery. I don't know if it's a peroneal artery that's diseased. I don't know if it's a combination of 2 or 3 or all of them. So we can't, you know, pinpoint or isolate a single vessel using this method. It's less diagnostic in insinuating the location of the disease than Doppler. So with the Doppler, we can track along the vessel and we can pinpoint that disease a little bit better.
Well,
11.
yeah.
Six, seven. It's difficult to perform in obese patients. So if you have a patient that's got a very large limb size, we're not going to get as much displacement of that air to get a large tracing. So it might be difficult in very large obese patients. Might even not even be able to get a cuff around some patients' limbs. So there's a couple different kinds of plethysmography that are available. Majority of these are actually not even used anymore. So some of these air filled and the strain gauge we don't even use anymore. So the main ones that we focus on are our pulse volume recording and then our photoelectric plethysmography. So those little clippies, the PPG sensors that we put on the patient's digits. Just keep in mind those photoelectric sensors, they're not technically a true form of plethysmography because they're not actually measuring volume changes. So that technology works a little bit different, but it still falls under, they still technically put it under plethysmography, even though it's not considered true plethysmography. Since photoplethysmography or photoelectric plethysmography. So on the test, you can answer either one of these. Interesting. UPG. Photoplethysmography. I think I say PPG in the question. So airflow plethysmography. So it works very similar to what we're doing here. So pneumatic cuffs are placed around specific levels, inflated. The arteriole moves through the cuff and measures volumetric changes as converted into pulsatile pressure changes within the air-filled cuff. Then a pressure transducer converts the pressure changes into analog waveforms. So volume plethysmography. So PVR, segmental volume plethysmography, or pulse volume recording, or volume pulse recording VPR. So these pulse volume recorder records differences in limb volumes for the blood flow in and out that occurs with each cardiac contraction. So again, as that pulse moves through that segment, displaces the air in the cuff. We can measure and get qualitative assessment of the overall limb perfusion, the amount of blood flow coursing through that limb. So this exam, our PVR exam, it's critical. It's important for us to do it. And that's why we always start with it, because we're doing this exam on patients that have peripheral arterial disease. A lot of those patients that have peripheral arterial disease are diabetic. And when patients are diabetic, their arteries become calcified. They suffer from this disease called medial calcinosis, where the medial layer becomes so calcified and thickened that we can no longer compress the arteries. So they have falsely elevated pressures. So their ABIs are going to be all out of whack. Their vessels might be non-compressible. We can't even obtain an ABI. And we rely solely now on this pulse volume recording in order for us to determine if there actually is disease present. So this is a valuable part of this exam, particularly in patients that have diabetes and artificially elevated pressures due to calcification. So we might do a patient who's been diabetic, their arteries are diseased, they have plaque and disease in their arteries. But their pressures, their ABIs might be 1, they might be perfect, well, they got perfect ABIs. But their pulse volume recordings are gonna look like doo-doo because they have disease. We're only getting those high pressures because of that diabetes. So that's why this exam, is the critical first part, and helps give us an indication as to like what we're up against too. We do that first part and we're all right, we got waveforms. All right, now it's not looking so hot. All right, now it's getting worse. And then we get to metatarsal and it's completely flat. In your mind, you don't have to struggle so hard to try and find those pulses, dorsalis pedis or posterior tibial. They might not even be there. Particularly if you got a flat metatarsal waveform, your pulse volume recording and the metatarsal is completely flat. There's no blood flow getting down, particularly dorsalis pedis. So you can always use that in the back of your mind, like I'm not hearing this, I'm not able to find the vessel. Yeah, because it's probably occluded. If you give it a good attempt, when you're trying to get your segmental pressures, you can grab your ultrasound machine, put a probe down and try and find it and see if it actually is occluded. So for PVR, the cuff width should be at least 20% greater than the limb diameter, or 40% of the limb circumference. We wrap the different segments of the extremity. So we can do this for the upper extremities. We can do this for the lower extremities. So it's important to use the same amplitude setting and inflation pressures for each segment to ensure accuracy and consistency. So with this, we can tell right away normal versus abnormal waveforms. So this is important here. So arterial disease is proximal or at the level of the cuff, showing the abnormal PVR waveform. So same thing with the patient's symptoms. I don't know, we mentioned patient symptoms. They would get cramping or discomfort. The disease segment is proximal to where that patient is at or proximal to where that patient is experiencing their symptoms. So we said if patient's getting cramping in their calf, the disease can't be further down past the calf. It has to be anywhere proximal to that calf muscle. So it's the same thing with these PVR waveforms. So if patient high thigh cuff is normal, but low thigh cuff is abnormal now, we know that disease is at that cuff or proximal to it. So it's going to be in between those two segments. If this was normal and this is abnormal, the disease segment has to be in between those two. If the high thigh cuff is abnormal, that means the disease segment is at that cuff or above. So it would be iliac or aorta potentially. If it's both legs that are the high thighs are abnormal, then we know automatically that it's aortal disease or aortoiliac disease. If it's just one leg that's abnormal, then we can't say aortic disease because that's going to affect both legs. It's just iliac disease. But we're going to get into that, a little bit later when we're looking at the actual exams and describing it. So our PVR waveforms, then we're going to select the proper cuffs. If we're doing it for upper extremities, they place cuffs on the upper arm, high forearm, and lower forearm. For the legs, we do, by our brachial cuffs, and we do high thigh, low thigh, calf, and ankle. These abbreviations, below the knee, above the knee, low, like drive me crazy, above the knee and below the knee. I always say high thigh, low thigh, calf, ankle. We also place a metatarsal cuff, and then we could do the great toes if indicated. So we're using our little PPG sensors or clips. You notice that the cuffs inflated to around 60 to 70 millimeters of mercury, and then held their pressure. Christiana, they calibrate their scale on the brachial level, and then try and keep this scale the same as they go down the legs. Depending on your lab, they might have specific scale settings for the different segments of the legs. Just keep in mind whatever your lab does. This is our cuff placement, which we know. Again, so if we're doing upper extremity, we have our brachial, proximal upper arm, distal upper arm, or I'm sorry, proximal forearm, distal forearm, and then one on the digit. This picture was just showing a 3-cuff technique, so there are some places that utilize a 3-cuff method with a single thigh cuff. So normal pulse volume recording waveforms. So there again, there's some characteristics that we look for all normal pulse volume recording waveforms. We have a rapid upstroke, so fast upstroke, coming to a nice sharp peak, and then we get a rapid downstroke, and then presence of a dichrotic notch. So that dichrotic notch is a bending backwards of that waveform and represents the presence of or the beginning of diastole. There's also a gradual diastolic runoff as well. That's common with healthy waveforms. But the main thing we're looking for is that nice rapid upstroke, coming to a nice sharp peak in the presence of that dichrotic notch. So the first thing we lose once we start developing disease is that dichrotic notch. The waveforms start becoming a little more blunted, a little more rounded. You can see here just kind of like the progression of disease. So we have the rapid upstroke, dichrotic notch. As patient starts developing arterial disease, that waveform starts to become more elongated, more rounded, our peaks. We lose that dichrotic notch. And as the disease gets worse and worse, it becomes broader and broader, more rounded, more elongated, and then flatter and flatter. So the amplitudes also start dropping as well. So like I said, looking for these abnormal waveforms will help us to indicate, the location of that disease or help to try and narrow it down. So for lower extremities, if it's abnormal at or below the high thighs, this is going to be iliac stenosis. So if it's abnormal at the high thighs, it's going to be abnormal all the way down the leg. So PVR waveforms don't go from abnormal to normal back to abnormal. That just doesn't happen. So for the disease segment, again, it's aorta iliac, it's going to affect everything going down the leg. So you're going to have abnormal waveforms going all the way down the leg. So that's why with patients that have multi-vessel disease, this becomes a little more challenging because we don't know if there's also disease, in the legs as well that are affecting those waveforms, unless it's really, really noticeable, where we go from bad to crappy to completely poop. And then we could tell, like, all right, well, that's a huge change, in that waveform from here to here. So there's probably something going on from there to there as well, So this is just kind of showing the breakdown. So normal high thigh, but abnormal to the distal thigh. So abnormal low thigh. So normal high thigh, abnormal low thigh. We know that's superficial femoral artery. Normal high thigh, normal low thigh. But abnormal at the calf, then it's got to be, between the calf and that low thigh is where our disease is. The popliteal artery. If it's normal high thigh, low thigh, calf, but abnormal distally by the ankle, then it could be tibial artery stenosis. The metatarsal or PPG cuffs, then we know it's small vessel disease in the foot. Just remember the limitations for this pulse volume recording, very sensitive to motion or tremors. They affect the waveforms, so those patients need to stay still. And then also being able to determine distal disease in the presence of inflow disease is also very difficult, like I said. So it's going to affect all the waveforms going down the leg. If they have proximal inflow disease, it's hard for us to detect or determine the extent of that distal disease as well. So this could be used, in operative setting in the OR for reconstructive arterial surgery. It could be used in the recovery room monitoring. So that one's super old. That's the one that's buried in the corner back there. That's our older one. Now we have more modern looking ones. Normal plethysmography monitoring waveforms. So again, they're going to look a little bit different depending on where you are, but they should still have a lot of the same characteristics. Fast upstroke, dichrotic notch. We see dichrotic notch, finger, dichrotic notch for the calf. So we still get a little necrotic notch. So we can sometimes have higher amplitudes as we're moving down the leg. Due to increased flow volumes from additional arteries coming together. But again, they all still have, same normal looking characteristics. That fast upstroke, coming to a nice sharp peaks, necrotic notch. So in terms of the boards, in terms of tests, I'm gonna give you questions. It's obvious if there's disease or not. You're not gonna be like, oh, that kind of looks normal. No, I'm gonna give you questions that it's obvious, normal, abnormal. And then very abnormal, so severely stenotic. So again, look for that necrotic notch, sharp upstroke coming to the peaks, sharp downstroke, gradual runoff. You can see, so normal. Got our necrotic notch, abnormal, we've lost that necrotic notch now, it's starting to become a little more elongated. The amplitude starts going down as you start getting more severe, so this now is starting to become even more rounded, the amplitude is much smaller, it's a much smaller waveform, and then becomes much flatter and flatter. So once we have severe disease, we're just getting little arterial pulsations. So that's why when Christian Vascular Lab, they often shut off the actual tracing and have you just listen for the sound for the pulses. So if that's all the waveform you're getting and you're trying to like get pressures, you really have to go based on the sound when it's coming back rather than looking at that waveform, because you're not going to get a nice, waveform coming back, even if it's very, very mild or very, very small or have a disease segment. So here we can see normal and then high amplitude and loss of necrotic notch due to the presence of potential collateral vessels. So upper extremity PVR waveforms, they look a little bit different than the legs. First thing you notice is that necrotic notch is a little higher up on that waveform compared to the legs. It's a little bit broader. But these are all normal looking upper extremity PVR waveforms. And lower extremity. So these are all nice, healthy looking, normal lower extremity PVR waveforms. Once we start really taking apart these exams, we're going to look at our ankle brachial index, our pressures, determine if that's normal. Then we're going to look at our waveforms, see if any waveforms look abnormal, and then we're going to look at our pressures and look for pressure drops between segments. Kind of just break it apart and see, if this patient potentially has disease. Yeah, so these are again just more normal looking, lower extremity waveforms. Versus something that looks abnormal now. So it's going to be obvious, abnormal versus normal. I'm going to ask you guys, which leg has the disease, which segment could potentially be disease. So we're eventually going to look at these and I'm going to be like, right leg, left leg, bilateral disease. So in this case, it would be bilateral disease because both sides look abnormal. Since the waveforms from high thigh, low thigh, calf, ankle all look abnormal. Like I don't see a single one on there that looks like a normal PVR waveform. We would say the disease again is at or above the high thighs, and since it's both legs, we can include the aorta in that as well. We don't know, but we just describe it as aortoiliac disease. So this was that chart just breaking down the levels of stenosis again. So looking at this example, which leg has disease? The left one obviously has the disease in it. The level of the abnormality. Since it starts at the high thigh being abnormal and affecting all the ones below it. We would say left iliac disease, since the right is normal in appearance. But once we get comfortable too, looking at our ABIs, you see ABI here of 0.73, ABI on the right side is 1.06. So we have a normal ABI, relatively normal looking waveforms. Which one's abnormal, right or left? Right leg. Good. So let's see what this says. Just stand back and when I'm that close, I can't even read it. So high thigh, low thigh, calf, ankle, metatarsal. This is at the calf now. Calf, the ankle, metatarsal.
That be like.
Right? Is that what it says? Thigh. Oh wait, no, never mind. This is calf. I'm sorry. This is thigh, calf. I can't even read it. Ankle, metatarsal, digit. All right, never mind. I'm sorry. So it's one thigh cuff. I'm sorry. So thigh, calf, ankle. Okay. Yeah, so this is calf. So it starts at the ankle.
Okay.
So it would be between those two cuffs and below. So this is abnormal too, like especially metatarsal is flat, but like that's the main thing between those two. Yeah, it's hard to read from there, but if you look on here, you can tell. In this case, it would be tibial artery disease. It's from that calf, between the ankle and the calf. Yes, no, maybe. Another thing I want you guys to be able to do is recognize the difference between plethysmography waveforms versus Doppler waveforms. So they're going to look a little bit different in nature. So these are normal plethysmography waveforms. And then we got a normal looking Doppler waveform. So Doppler waveform looks like our arterial tracing. It is an arterial tracing. It's a Doppler tracing. So in a healthy waveform, we look for triphasic waves. On the report itself, you'll see a zero baseline going across the screen for Doppler waveforms. Plethysmography waveforms do not have that zero baseline, so you can help use that to help recognize it. So this is just kind of like an example. So these are your plethysmography waveforms. We don't see any zero baseline. Whereas on your Doppler waveforms, this is your zero baseline. So you can see the zero baseline kind of right there. Right there's zero baseline. In this case, this was the upper extremities. So we have right arm, left arm. Left arm looks fine, looks normal. We got nice dichrotic notch, sharp peaks, rapid upstroke. Whereas on the right side, we get a more gradual upstroke, rounded, lower amplitude, no dichrotic notch. And the upper arm's abnormal, so we know the disease has to be above that upper arm. So whatever vessels are proximal to that upper arm cuff. So it could be axillary, it could be subclavian. And then the Doppler waveforms comparing them look different as well. So on the left side, we see all triphasic waveforms. Particularly, and then we get into pulse, I mean, they're above the baseline, but still look much higher resistance compared to the right side. So the right side definitely has disease. Skip over strain gauge. Can you just, which one's normal? Severely obstructive.
Okay.
A, severely obstructive C, moderately abnormal B. This is probably an older version of plethysmography where they'd actually stick their hand in water bath to displace the water with each pulsation. So this is probably like the advent of like, hey, like I got an idea, let's figure this out, you know. The people that thought of all this modern technology. All right, so photoelectric plethysmography, PPG. So again, this is not a true form of plethysmography. It detects cutaneous blood flow and pulsations rather than volume changes. An infrared light emitting diode transmits infrared light into the superficial layer of skin, and a photoreceptor receives the reflected signal. The resulting signal is related to the number of red blood cells in the cutaneous circulation. So it's essentially measuring the amount of blood, the number of red blood cells that are circulating in your superficial tissues. So we can determine the amount of blood flow perfusing in that extremity. This is valuable when we have low flow states, so very slow flow or very low flow volume states. Also with patients that have those arterial wall calcification situations. So oftentimes a lot of labs will do this regardless if the vessels are non-compressible or not on any diabetic patient. The photocells are also very extremely sensitive to light, so it's best performed in a dimly lit room. It's just showing the PPG and the placement. So we got to use this. You place the, if we need to obtain pressures, the cuff goes on the base of the hand or the foot, the PPG sensor on the tip. Again, we could use the clips, double-sided tape right here, stick it to the digit. So this was just showing the PPG with cuff pressure. So it didn't look like that at all for us. But we inflated until it went away, and then at that first pulsation coming back, we indicates the pressure of that that digit. And normal PPG waveforms, rapid systolic rise, diachrotic notch, gradual diastolic runoff. So this is for now upper extremities. So there is one waveform that I want you guys to be able to recognize, and it's the one for Raynaud's disease. So Raynaud's disease is also termed a peaked waveform. Raynaud's disease. Put peaked in quotation marks. Terrible when I'm drawing this.
That's good. That's better than your hand one.
I was?
Yeah.
That's good. So there's a couple of features for these peaked waveforms. Let me show on camera here. There you go. So it doesn't really show very well on here. But with Raynaud's disease, we have something called an anacrotic notch, an anacrotic notch, A-N-A, crotic. Ancrotic notch. Instead of a dicrotic notch on the other side of the waveform, we have an ancrotic notch on the systolic upside of that waveform. So I drew it kind of exaggerated. The pictures I'm going to give you for your exam you're definitely going to see that ancrotic notch. So it's going to be very obvious. The other characteristic is the dicrotic notch is moved towards that peak of that waveform. So you have a very high dicrotic notch near that tip or peak of the waveform. So I'm going to say a high dicrotic notch. All right. Dicrotic notch. There's an ancrotic notch, there's that high dicrotic notch. So these are the characteristics for Raynaud's disease. Raynaud's phenomenon looks very similar to proximal obstruction. So like it's really hard to differentiate the two, but just remember that with Raynaud's phenomenon, those people have peripheral arterial disease. So it is some sort of obstructive disease in combination with the Raynaud's disease. So you can see that's much worse. So Raynaud's disease, they still have fairly decent perfusion, but it's just that vasospastic disorder. But Raynaud's disease is often referred to, that waveform is referred to as a peaked waveform or peaked. So this was just showing now. Normal waveform, nice dicrotic notch, rapid upstroke, fast downstroke, gradual runoff. This one's more rounded now, lost the dicrotic notch. And then our peaked waveform associated with vasoconstricted artery or Raynaud's disease. We have an ancrotic notch, so you can see a little bit on this one. That dicrotic notch is moved up towards the peak of that waveform, so it's displaced, a high dicrotic notch displaced upwards. That's the peaked waveform associated with Raynaud's disease, primary Raynaud's disease. Chart just describing some of the characteristics. Normal versus an obstructed waveform versus a peaked waveform. So these are both abnormal. The first one represents an obstructed waveform. Second one represents that peaked waveform, also abnormal. This is now just showing PPGs for digits. So these are all considered normal waveforms. Versus patient who has, in this case, they did compression for the radial artery. And they demonstrated, so they were doing what's called an Allen's test here. In this case, when they compressed the radial artery, everything went flat in their hand. So they had PPG sensors on all the different digits, getting their waveforms. When they compressed the radial artery, everything went flat in that hand. So we'll learn about how to diagnose incomplete versus complete pulmonary arteries a little bit later. What's the formula for ABI? You guys are so done.
We're trying.
You're trying.
The pressure is divided by the highest rate.
One of the something pressures divided by the higher brachial thingy. Close enough.
Harper.
If I see it on the page, it's good.
See it on the page, it's on the screen.
Look at that.
What do you know?
You're really paying attention.
They're little footballs.
I'm blind. I
Alright.
can't see that. They're mean.
Fun of my vision.
Uh,
We're so
Thanks so much.
insensitive in this class.
Alright, Dan, we're getting into torture here
I'm getting into Twitch.
now.
Lectures from 9 to 12. We still have half an hour.
That's
Tortured its own, I know.
you know, it's proven that the brain doesn't really pay attention after 90 minutes.
That's what they say.
I
That's what
believe
they
it.
say.
I
You'd be
believe it.
surprised. I think that's a product of our world now with like all the phone. I don't know. I had a school, I had to pay attention when I was a kid. There was no,
Your classes are 3 hours long.
we had, yeah, oh my God, my ultrasound like echo teacher, there was no PowerPoints, there was no notes. Like she just came up there and talked. She drew stuff on the board when she felt like it, but like you had your tape recorder and you were recording, writing like everything word that came out of her mouth. You
You had a
played
tape
your,
recorder?
yeah, she allowed that.
Yeah.
So everyone had their, we were like field reporters, everyone had their tape recorders on that front desk. And like, we'd go back after the class and like, just be playing it back and like, you know. Yeah, it was brutal. That was her, like. But this is how I felt in my OBGYN class. I was in the back of the room, lights were off and dark. Like, I was out. My teacher hated me. That's all right, though.
Did it?
I made it, exactly. I'm just like, follow seal, I don't know, like, that was my answer for everything.
Good one.
Hermeli syndrome. Eye drops, could be fetal eye drops, cluster of grapes. Polycystic ovary. Bananas, there you go.
Banana.
Hydrocephalus, holoprosencephaly. I don't even remember half of that stuff, man.
You have our full attention.
If you dance the rest of the class while you're teaching.
I do. Just like throwing chalk at you guys.
Something.
Aggressive Deltec teacher going. It's going on YouTube anyway, so like I gotta watch what I say and what I do. So
You're gonna cut this part out.
I don't know how to edit. God. The teacher said, what?
Next week, we're gonna come in and Dan's not gonna be.
I know, I'll be tough, like,
I'm gonna be professor.
God,
It was a joke, so, huh?
it's a joke, it's a joke. They didn't mean it. I
Man, how many subscribers you got on YouTube?
don't know. How many classes have I had? Pick up.
Come on, Dan, I'll go subscribe to you right now. I've been subscribed.
You're subscribed?
I sure am.
Dan, what's your name? Dan the teacher?
Just my name, Daniel Hernandez. I don't know. You probably put in like vascular something or another, it'll probably pop up.
The video.
Kashi69 just popped up, so.
No, it's not me.
Didn't you post? What was
What?
it? It was for Terry's class last year.
Oh, yeah.
I looked up your name, so that is not Daniel. Is it you?
Oh my God.
That's good.
It's it.
Let's go back.
There you are, Dan. Well, oh man. See? Oh my God, you're famous.
Yeah.
That's some videos.
I think some of them are final review. Those are the good ones to.
So I don't even be here that
Your class offered online, Gail. Might have been on there. All right, anyway. Segmental limb pressures, so the second part of our test. So we have 3-cuff technique, 4-cuff technique. When we're insonating, so the term insonate means to listen or to sample. So when we're doing our segmental limb pressures, we're insonating or sampling that vessel, either the dorsalis pedis artery or the posterior tibial artery when we're doing the legs. If we're doing an upper extremity PVR SLP, we're going to use the radial artery. 3-cuff technique versus 4-cuff technique. Here we utilize that 4-cuff technique. Again, your ankle brachial index is the systolic ankle pressure divided by the higher of the 2 brachials. So the ankle systolic pressure will either be from the dorsalis pedis artery or the posterior tibial artery. Take whichever one is higher for those two. When we start analyzing our pressure measurements, we're going to look at differences in pressure between 2 consecutive levels and also horizontally. So we're going to compare pressures up and down vertically as well as horizontally to look for any abnormalities or differences. Again, so this SLP exam is usually combined with the PVR exam or a Doppler exam. Again, the patient should be resting and relaxed. Just to remember, when you're inflating those cuffs, use the appropriate cuff size, the cuff placements, make sure they're wrapped properly, nice and snug. You don't want them too tight or too loose. Too loose, you'll get falsely elevated pressures. When we're insonating and obtaining the pressures, we want to inflate those cuffs about 30 millimeters greater than the last detectable sound to allow for that gradual runoff. So again, cuff placement for the legs. We have our brachials, and then we insonate the dorsalis pedis and the posterior tibial arteries. Find out which one is the higher of the 2 and utilize that one to obtain the rest of the pressures. For the ankle, calf, low thigh, and high thigh.
It's a beer. Don't mind.
Sounded good. Was it your Pepsi?
Yeah.
Nice.
Cherry Pepsi, you know, Dan. Am I not predictable?
You had a cherry Coke shirt on the other day or last week, right?
Yeah, I'm not a.
What's that about?
fan.
Oh,
Well, there was no.
There's no Pepsi shirts?
So.
that's all right. So this is just showing the cuff placement again for 3-cuff versus 4-cuff technique. So with that 3-cuff, we have the single thigh cuff. So that will actually give us more accurate thigh pressure measurements. It's contoured to the thigh, fits nicer, gives us a more accurate pressure measurement in the thigh. But just the issue is we can't differentiate the disease in the thigh. So again, if this is abnormal, it could be anywhere along that thigh cuff or proximal. Whereas if with that 4-cuff technique, we can now tell if the disease is femoral versus, more proximal. If it's SFA versus, something more proximal using that 4-cuff technique. We know where to get our pressures. This is just showing. If need be, actually, I didn't mention to you guys before, but you can actually pick up the peroneal artery coming anterior to the lateral malleolus. So above that lateral ankle, you can actually pick up a peroneal artery signal. So for upper extremities, when we're doing our SLP, we're looking for differences in pressure greater than 20 millimeters of mercury. I know here it says 15 to 20. I'm going to use 20. The board uses 20. So we're looking for differences greater than 20 millimeters of mercury between segments if we're doing upper extremity. If you're doing a lower extremity and you get your brachial pressures and you see a difference between right and left of greater than 20, retake it. Absolutely retake it. Just to verify, because if there is a difference greater than 20 between your 2 arms or 2 brachial pressures, that could indicate the presence of either subclavian steal syndrome or some sort of central stenosis in the extremity that has the lower pressure. So you might find a disease just in the course of doing this exam, something wrong with their vessels more central, that they could potentially need some sort of intervention for. So for lower extremities, that pressure difference is a little bit higher, so we have a higher threshold. So we look for differences greater than 30 millimeters of mercury to indicate the presence of disease. So we're looking for pressure drops. So pressure shouldn't go up, between segments as we're working our way down the legs. They typically go down. So we're looking for, again, for those pressure drops between segments vertically as well as comparing horizontally. ABI, a normal ABI range, ankle brachial index, is normally between 0.9 and 1.3. Christiana goes up to 1.36 actually. Another thing to note is that those, like we said, those pressures typically go up as we go up the leg. So the thigh pressure should be higher than the ankle pressure. So typically a normal thigh to brachial index is going to be greater than 1.2. The boards uses 0.9 as kind of the cutoff for the thighs. So if you get a thigh to brachial index that's less than 0.9, that 100% indicates, some sort of aortoiliac disease going on. Toe pressure index, the boards and I use 0.6. So over 0.6 indicates healthy. I don't think I'm gonna ask you guys to be honest, toe pressure indexes on any of the exams, but just so you guys know, greater than 0.6 is considered normal by Christiana standards. So as those ankle brachial indexes drop, that indicates more significant disease. So we said normal 0.9 to 1.3, mild disease 0.8 to 0.9, moderate peripheral arterial disease 0.5 to 0.8, less than 0.5, severe disease, critical disease less than 0.3.
And
Yeah.
you said. The pressure should be higher, like the higher you go on the leg.
Yeah, they typically go up as you work your way up the leg. So some pitfalls for our segmental pressures. Again, we can't localize the exact area of the obstruction or disease. Our diabetic patients who have the medial calcinosis will have falsely elevated pressures. So patients with calcified vessel disease, particularly our diabetics, have falsely elevated pressures. It does not indicate relative significance. So it's hard to indicate significant multi-level disease. So it's hard for us to really pick up like how significant multi-level disease is. Another thing to also consider too is this last one. It's also kind of important that patients who have deep vein thrombosis or DVT, blood clots in their veins, or superficial thrombophlebitis, clots in their superficial veins, we should not be performing this SLP exam. We could potentially dislodge a blood clot and create a pulmonary embolism. So if they have blood clots in their legs and we put these cuffs on and we start inflating them, that pressure could be enough to dislodge a clot and create a pulmonary embolism. So we can send the clot shooting off to the lungs. So if you have an instance where, they have 2 exam orders, they have a venous study and then an arterial study to do this, do that venous exam first to make sure there are no blood clots. Because if there are, you're not going to be able to do this. Potentially you could do it if they do have a DVT, if they've been on anticoagulation, if they've been on intravenous heparin or some sort of anticoagulation treatment for a period of time, then it could potentially be safe to do this. But, if they have a fresh acute DVT, you're not doing this exam.
What if you don't know if they have a clot?
Well, that's why you do the venous study first. If they just ordered this and
Yeah,
you don't know, then you just don't know,
Terrible. That's scary.
It is a little scary. But then hopefully the doctor, ordered properly, hopefully it's just an outpatient coming in with known peripheral arterial disease, that they're having the symptoms of claudication or cramping or stuff like that. It's not someone coming in with a big swollen leg, that like is edematous and, you know, it's warm and it's red, that's like venous symptoms, then I'd be like, well, hold on. This is probably a DVT, not an arterial issue, you know, like you're ordering the complete wrong thing here. Hopefully they've at least ordered both, but. So this is just showing, normal, PPG waveforms with the pressures. Again, look at your breakup pressures, 106, 106, perfect, ideal, 100, or 109, 107. So normal pressures, no significant pressure drops. Now this was comparing, doing upper extremity, right brachial and left brachial. So right away, you can see difference in pressure, 130 versus 96. So that's over that 20 millimeter threshold. So you know something's going on that left arm. And you can see the waveforms look different as well. So these are much higher amplitude compared to those. And then the pressures again go from 130 to 124, 90, 96 to 91. But when you compare those two side by side, again, that's greater than 20 millimeters of mercury. So this looks like there's something, again, the disease is proximal to where that first cuff is. This can be probably left subclavian. It's the most likely source. Now for the legs, we're looking for a larger pressure drop, greater than 30 millimeters of mercury between segments. So same thing that we were able to look at the PVR waveforms, the same holds true when we're talking about pressure gradients or pressure drops. So the disease is at or proximal to where you see that pressure drop or the cuff with the lower pressure. On here. There we go. So this one's got a good pressure drop. So brachials are fine. We're good with the brachials. They look pretty similar. Then you look at your ankle brachial indexes. On this side, we have 0.7 and 1. So we know that the right leg is abnormal. We have an abnormally low ABI. Then you start looking for pressure drops. So you start at the high thighs and just you're working your way down the leg looking for pressure drops. So 188 to 177, no, that's fine. 177 to 133, yeah. So we're dropping 44 millimeters of mercury at that point. So that's considered a significant pressure drop. So we go to the cuff that has the lower pressure, the disease has to be at or proximal to. So it's between those two cuffs. So we had no disease in this segment. We didn't see any pressure drops, so everything's good. We didn't lose any of that pressure energy. There was no stenotic lesion to lose that pressure energy. So, you know, the pressure is maintained fairly well going through this segment. We'd expect them to, you know, to drop normally. We get through to this next segment, we go from 177 to 133. Uh-oh, something happened. We lost a lot of that pressure energy, you know, going from here to here. So that disease segment has to be somewhere in between. As we continue working our way down the leg, we go from 133 down to 93. That's another significant pressure drop. So there must be something else going on in this segment as well to create that significant pressure drop as well. So in this case, that patient has probably multi-level disease or does have multi-level disease. So they would have, you know, popliteal as well as tibial peroneal disease. If you look at the other side, you know, 191, 170, that's fine. Still less than 30, 170, 160, less than 30. And then 160 to 143, less than 30. So there's no evidence of disease on the left side. This was, I know, I just kind of going back up. So this was again a normal study now. So brachial pressures look fine, they're pretty similar. ABI is both 1, that's good. Look, this one should be over 1. It's a little over 1 as well, but close to 1. So then looking for your pressure drops, you know, 182 to 160, less than 30, you're fine. 160 to 146, still less than 30, and 146 to 130 is fine. And also when you're comparing across, they're pretty similar as well. So you don't see anything major comparing the levels horizontally. So no significant pressure gradients observed, normal patient. So with this guy, we see. All right, brachials are fine, okay, and then we look at our indexes, 0.6, 0.7. So that's about abnormal on both sides, so those are both low. But when you look at your actual pressure drops, you don't see any significant pressure drops between, the actual segments to indicate, the presence of any disease in the legs. But if you compare your high thigh, to your brachials, this is 1. And then this is less than 1, so that's by 0.9. So this could potentially be, aortoiliac disease, because those high thigh pressures are kind of low or getting towards that low end.
Wait, where are you putting the index from?
I'm just kind of comparing these numbers to your brachial pressure. So the higher the 2 brachial, so 140, 140, so that's 1. 130 over 140 is a little bit less than 1.
I thought you did the ankle over the.
Well, in this case, it's the thigh over the brachial.
So 140 over 130.
Yeah. Oh, 130 over 140. So use the higher of the 2 brachials still. Yeah. Da-da. So other things to consider for this SLP is we could use it to follow, a patient over a period of time. So if we're doing follow-up exams and we see changes in those ankle brachial index, if it starts dropping greater than 0.15, that could indicate disease progression. Also, when we're dealing with patients that have non-healing wounds and they have ulcers on their extremities, if we get an ankle systolic pressure that's less than 55 millimeters of mercury, that wound is not likely to heal. So that's very low pressure, getting down the leg and down the extremity. So if they have a wound on the top of their foot, wound on their toe, there's not enough blood pressure to bring perfusion or adequate blood supply out to that wound to allow it to heal. With diabetic patients, because those arteries are starting to be calcified and they're falsely elevated, our measurements or our threshold or cutoff is a little bit higher. They use 80 millimeters of mercury in diabetic patients. So we talked about that coarctation. If we see a difference greater than 70 millimeters of mercury between the brachials and the ankles at rest, that could potentially indicate the presence of coarctation. So that's very, very high brachial pressures compared to very low ankle pressures. The patient's brachial pressures are, like 150 and the ankles are 80, or less than 80, that could potentially indicate, the presence of significant or presence of coarctation. So this is showing the toe pressures. I'm actually getting into like being able to read these. We'll do this with a fresh head. That's where are we at? This is the fun part. All right, we can do the fun part.
What is fun about?
This is a game to you.
I actually can't read this.
You know what I can do here?
What did you
Guys,
guys?
that's last we have to do. Yeah, it's 2 against 1 here. Doesn't I do not want to continue?
Tie vote. Still can't read it.
So it's a 5 vote.
What about now?
Oh. Fine.
All right, guys. Ready? Speed run. Normal. Next.
Yeah, it is.
Agreed.
It is.
Cool.
Yeah. On to the next. Abnormal.
Normal.
No, I'm not even
At
gonna
the
take a
top.
look at it.
And all the rest of them too, actually. Potato, potato. No, tomato, tomato.
Oh,
It's going
what's going on?
No, what line are we on? We're on 80? Oh, that's abnormal, right? Yeah.
Yeah.
We are done with
Yep, abnormal left. And it's starting all the way up at, so these are, so also
I thought, right?
PVR or Doppler.
That's Doppler.
These are all Doppler waveforms. We see our zero baseline.
Why does it go from? Why does it get higher and then lower again? On the right one?
On the right one. Over here.
Mhm.
They're all pretty similar. So
That's normal.
yeah, it's normal, like, yeah. So it's not as significant. So we won't go from like, you'll never go from like 122 up to like something much higher, like 150 or 160. That typically doesn't happen unless, of course, they're diabetic and those arteries are starting to become calcified. So diabetes throws this whole thing off, unfortunately. But diabetes will also make this higher as well too, so. All right. 23-year-old female smokes 3 packs a year. Oh, she barely smokes. She's losing her hair. Oh, she must be stressed.
Oh, which one?
Oh, she's pulling it out. Oh,
Um,
yeah, for arms, everything looks all right. Right, all the waveforms look symmetric.
mhm. Yep, so,
He's chilling. The digits all look fine. She's got good flow to digits. Yeah, so it's a
Fine.
normal study.
Yeah, I'm drinking that 3 pack.
Drink some water.
Yeah, she barely smokes. 3 packs are, what is it? 3 packs a year?
Yeah.
Yes,
that's-
big conflict.
Yeah.
Period. It's
Period.
period.
No.
Wait, are we on the next one? A3?
Yep.
My interpretation of this is, normal. Normal.
Yes, with Doppler waveforms now. So I just recognize, again, PVR waveforms versus Doppler waveforms. On the test, I'll ask you to evaluate are these normal Doppler waveforms? Are these normal PVR waveforms? Is there a disease? Yes or no? Hyperemic, all right, so this is like actual, some case studies now. The date of exam was 2001. Who wasn't burned yet?
Bird.
Oh,
I was born.
You were born
wait, what year?
2001.
Oh, I was born.
You were born.
By what, like 1 year?
Christmas.
I feel like my
1922.
thigh is a big jump. No?
Brachial to high thigh.
Mhm.
So we want over 1.2 is considered normal, so that's fine. So again, the pressures go up as you go up the leg.
So this one,
I don't get it.
this one's normal.
Yeah, so brachials are fine. We have no issue with the brachials. We don't have to remeasure, so we can use 187. That's good. Jump down to your ankle brachial index, 1.11 or 1.13 and 1.07. Those are both normal. So that's a good start. We're off to a good start. We got normal ankle brachial indexes.
Next, bad.
What's bad?
The next one.
Which
Bad.
She's jumping ahead.
Which one? Oh, the next one after this?
Yeah.
Yeah, so everything here looks normal.
Yeah.
All the waveforms look normal. I mean, granted, some of the amplitudes are, going off the screen or whatever, but no significant pressure drops between the legs. I mean, the main thing is they're hypertensive. I mean, their systolic pressure is 187. So this guy has high blood pressure. Female has high blood pressure.
Bad.
This one's Doppler.
Yep, correct. This is Doppler. Yep,
This one is doo-doo.
this one's doo-doo. It is, yeah, look at those ankle brachial indexes.
They're both
So this is toe pressures here, but ABI on the right,
bad.
0.45, 0.66.
It jumps horizontally. Okay.
Yeah, so on the right, they're all very, very low.
Yeah.
So that means the disease definitely has to be right iliac, 100%. On the left side, we can see, let's see, this is common femoral. We get something that looks, kind of looks triphasic, so that's not bad. But when we get down to femoral artery, that Doppler waveform changes. And it continues, down the leg. So we got something going on, between that common femoral and, between common femoral and, femoral. So this is close, this is pretty close to that 30 millimeter mercury, so that's, something's probably going on there. Also, our high thigh pressure is starting off kind of low, we're around 1. So there might be something, a little something going on in the left external iliac as well. Definitely the right.
Next one's bad.
Next one's bad too.
Left leg.
Left leg, good. This is more example, like types of questions you're gonna get. Identify which extremity has disease.
Would this be, this would be. Like obviously left, but it would be like iliac.
Yeah.
Cause it starts off bad all the way at the high thigh, right?
Yep. Right leg, what's our ABI? Oh, yeah, 1.2.
Oh my god, this dude's foot's falling off.
This dude's foot falling off next.
Sorry,
Are you talking about a call?
I'm talking about the next guy, his toes are falling off.
Oh my god.
Zero, we're at 0.00. That's real bad.
Real bad, Clark.
They're both bad, but the right leg is not doing good.
Yeah, so they couldn't even hear the dorsalis pedis pulse, so they got a 0 for that. They weren't able to insonate it. They didn't hear it. 0. They got 22 millimeter mercury for the posterior tibial artery, so that's super low. Yeah. The metatarsal, or actually, what is this? Dorsalis pedis absent. They put posterior tibial, their Doppler waveform was monophasic, very dampened. But looks like the issue starts in the femoral artery. So their popliteal waveform, so we went from femoral biphasic to monophasic in the popliteal. The pressures, went from 151 down to 101, then down to 61. So there's definitely down to 22. So this guy's got multi-level disease all throughout that leg.
Okay, the game's over.
Game's over. All right.
There's another game, but that's a lot of math.
Wait, so it starts in the common femoral for that?
No. Daniel?
For that previous one?
Yeah.
Yes. Yeah.
Because the one on the top is normal, right?
Yes. Yeah, that's triphasic. Yep.
Pretty bad. Okay.
Yeah.
This is done.
I know you're done. So for your, I'll give you guys calculators, but I just want you also to just be very comfortable being able to calculate your ABIs. Know which, most important thing, just know which number you're going to utilize for your ankle brachial indexes. For ankle, you take your 174 divided by the higher of the two brachials. So 174 divided by 162. For the right side, left side, 176 divided by 162.
we got a calculator? for this?
Yes, or you can even just give me the fraction, I don't care.
Oh, you did? I'm so not.
What?
great.
Yeah, I'll give you the calculator, and you just write the fraction.
I'm sorry. Please forgive me.
This is the corner.
I'm just-